Welcome. Yes. So welcome all. And on behalf of Michael Barkham and Louis Castanet, I would like to welcome you to the 8th webinar of our webinar series on the 7th edition of the Bergin and Garfield Handbook of Psychotherapy and Behavior Change, which is jointly sponsored by 3 organizations. As you know, SPR, SEPI, and the APA Division 29, the Society for the Advancement of Psychotherapy. And as you have probably all heard or seen on the SPR listserv and in the many tributes, statements from SPR colleagues around the world, we have some very sad news today. Alan Bergin unfortunately passed away last week. He's a great loss to psychotherapy research. He's one of its founders. Alan was a co-founder with Sol Garfield of the Handbook of Psychotherapy and Behavior Change, and the first edition of which was published in 71. Yes, this 71 edition. He was president of SPR from 74 to 75 and received the Senior Distinguished Award in 98. On our society website, I found out that he was already participating in one of the pre-SPR conferences in 1969, basically establishing the society. He was also a mentor to many SPR colleagues. And of course, I cannot name them all today, but I want to mention here Mike Lambert, who was the editor of the 5th and 6th edition. And one of our speakers today, of course, Gary Burlingame. And I'm sure Gary will maybe say a few words later too. Alan also was very supportive of this current edition of the handbook, being enormously encouraging throughout and writing a preface for it. And he also got Albert Bandura to write an endorsement. And he also read the entire book, all 800 plus pages himself, and being over 85 years old. And Michael, Louis, and I are very happy that we had the opportunity to have him and Mike Lambert in the first webinar of this series, which you'll find on our YouTube channel. And you are all welcome to watch him and to learn about the fascinating history of the handbook. And it also might be interesting for some of you to go to the end of the new edition, the 7th edition, and look at our summary charts of all the 7 editions. And yeah, so there, before we begin, I would like to ask all for a moment of silence. Okay, so today's topic covers again a highly important topic of psychotherapy research, dissemination and increasing scale, and on a group as well as internet interventions. Both topics are increasingly meaningful in recent years and have seen a lot of research activity. And I'm so glad we have such excellent speakers and distinguished authors for the handbook. Gary Burlingame, who did the handbook chapter together with Bernard Strauss on small group treatments, and Gerhard Andersson, who did the book chapter together with Thomas Berger and on internet interventions. So many thanks to all of you for coming in, to logging in, and for those who are here the first time. This webinar series, you can also find the previous webinars on our SPR YouTube channel, which I highly recommend. SPR has become a huge resource of psychotherapy research presentations. and from colleagues around the world, and it's great material for teaching. And of course, our webinar series adds to that material. And please also join our next webinar session. This is on March 14th, which will focus on increasing precision in the psychological therapies, and which will be held by Mai Ning and Zach Cohen and their chapter teams. So, and we will of course announce it early. So Gary, please go ahead, share your files, and you're welcome to start. We have actually 3 parts. So the first, the individual presentations from Gary and Gerhard, and then we have also time for questions and answers, of course. Does it work? Yeah, excellent.
Does that work well?
Yes, perfect. We see it perfect.
Okay, good. I did want to just take a moment before I dive into this chapter overview to acknowledge, you know, in a way, I wouldn't be doing this talk without Alan Bergin's mentorship and influence. And when I was a graduate student looking for a job, I felt real lucky that I got to come down and as a young faculty and work with Alan. Dick Bednar was here at BYU at that time. Of course, Michael Lambert was here. So it felt like a hub of psychotherapy research, including my interest in group. Alan was an important person for me. He connected me with Irv Yalom. There was a parade of people I'd read as a graduate student in the psychotherapy literature who came through BYU because of Alan's presence and stature in the field. So this is one small honor, but I wanted to sort of dedicate this overview of the handbook chapter that Bernhard and I, this is our 3rd one, to Alan. With that, I'm going to be looking, my notes are off on the screen, so I'll be looking away from the camera. I apologize for that. So this is a chapter that Bernhard Strauss and I started about 25 years ago. This is our 3rd chapter. And there's been some noteworthy changes since our last chapter. The first is in North America. Group psychotherapy was approved by the American Psychological Association in 2018 as a specialty. And this specialty recognition is equivalent to the specialty of clinical psychology, family psychology, and so forth. And really, it was based on the maturity of the empirical, theoretical, and clinical literature. And actually, the handbook stuff was part of the petition for the APA recognition. Secondly, as we noted in our 2013 chapter, the majority of our group RCTs, and there's a ton of them, I'll show you a high-level overview in a second, are conducted by specialists in either a particular disorder, like depression, or a theoretic orientation, like CBT, for instance. And group doesn't seem to appear to be a part of their core identity, which contributes to some of the limited exploration of the mechanisms of change and group process variables that we'd love to see more work on, but I think it's a part of who's doing the research. And the third thing just to note is the rigor of the research that Bernhard and I had in this chapter has really increased. There are more manualized protocols, more fidelity checks, more random assignments, just better overall rigor. We begin the handbook chapter with a model of group treatment that was used in the APA specialty, which describes the 3 major types of group treatment and really the 3 primary areas of research. There's just a plethora of leaderless group literature out there. And these groups are composed of individuals suffering from a common medical, psychiatric illness. And these include support groups, self-help groups, and 12-step groups. We only include these in the handbook chapter when they're compared to psychotherapy groups, because the literature would be too huge otherwise. Psychoeducational groups are basically a disease management approach, like used in physical medicine. And a primary goal here is information and skills to help manage disease. But in the group psychotherapy literature, they're often tied to a theoretical orientation like CBT or ACT. So you'll have the information and skills plus a theoretical orientation. And then lastly, psychotherapy groups, which was the primary focus of our chapter, two types. The manualized ones, these are time limited, guided by a specific theoretical orientation, often very specific group and session goals in these manualized groups. And then model-based ones are more more principle-based, less structure. Interpersonal groups would be an example of this type of group. Let's see if I can make that slide go forward. There we go. So most of our chapter summarizes the efficacy of group treatment for specific psychiatric and medical disorders. And Bernhard and I partnered with international experts after our last chapter to conduct a large number of disorder-specific group meta-analyses. I noticed Jenny Rosendahl is on the a member, and she participated in many of these. We have over a dozen of these now published, and 10 are summarized in our chapter. And this slide lists the inclusion criteria. But the primary goal, in addition to the criteria on the screen of these, was to have each meta-analysis look at what the practice guidelines were, NICE, APA, and others, and then compare that with what the most recent literature supports, and then make practice recommendations, if you will, revisions, if you will. And these meta-analyses used a common code book, and we used 3 comparison groups. The reason we use these 3 groups is because, well, I used to be a group coordinator, and they're the kind of questions patients ask. So the first comparison group was a waitlist control. And a lot of times when you're trying to recruit a patient into group, one of the things they're saying is, well, maybe I won't go into therapy at all. Maybe I'll do no treatment. So we have improvement rates for those who choose to go into group versus waitlist control. Then treatment as usual is a second comparator in most of the meta-analyses. This is treatment in the community. And a lot of times what we're trying to do is, and you'll see these in the meta-analysis, invite a patient to add an evidence-based group to what they're already doing. And then lastly, the third comparator were active treatments. Most commonly individual therapy, medication, sometimes placebo attention groups fall in here. So to address past methodological challenges, we have a fair amount of mixed findings in the individual versus group comparison, and some of that's methodological. We conducted a meta-analysis to test outcome differences between individual and group using a 25-year span. It was a little under 70 studies, and the bulk of them had identical comparisons. So the group and individual had identical treatments, identical patients, identical dose. But there are also a couple dozen randomized clinical trials we called non-identical, and this non-identical either on treatment, patients, or dose, or some combination of those. Now, the effect sizes for the identical comparison was virtually 0. And there were no differences in rates of acceptance, rates of dropout, rates of improvement, and remission. Now, when you looked at the other group, these are the non-identical studies. The between study effect size heterogeneity was high in contrast to the identical. So we did a moderator analysis to try to understand what was going on with those few dozen studies. And allegiance was a significant moderator. So if you favored group, guess what got better? Group. If you favored individual, same thing. And the difference between those allegiance was a G of about 0.3. So we found that to be rather interesting and maybe explaining some of the past mixed findings. So we introduced in this chapter something that we'd use in our last chapter, and that is group is primary. And what primary means is that the group is the principal treatment that a patient is getting. Mood disorders are a piece of that, and we begin with the major depressive disorder. When group is compared to waitlist control, we had large pre-post effects on depression and recovery. So for instance, group members were 6.8 times more likely to be classified as improved with no heterogeneity when compared to waitlist control. That's a big number. In the treatment as usual comparisons, and again, don't forget what I described with treatment as usual, 2/3 of the studies tested treatment as usual versus treatment as usual plus the group. And that produced moderate to large pre-post improvement favoring group. And group members in this comparison were 5.3 times more likely to be classified as improved. But those effects were heterogeneous. And finally, there were no differences in symptom improvement, rates of recovery, and attrition when group was compared with medication. No heterogeneity on that. A second mood disorder is bipolar disorder. And there were no waitlist control bipolar studies. So the primary comparison was treatment as usual. There were 6 treatment as usual comparisons. And a significant moderate improvement was found with significant heterogeneity. So that was tweaked. And one way it was tweaked was only comparing improvement on primary measures. So this would be measures specifically to capturing bipolar symptoms. Moderate improvement and the heterogeneity disappeared. And when group was compared to medication alone, there were no differences in improvement, rates of recovery, or attrition, and no heterogeneity. So there's a bunch of meta-analyses that have been published. These have come primarily out of Bernhard's lab with Jenny's support. 4 of them looked at different anxiety disorders. CBT was the dominant treatment for social anxiety disorder. So when CBT groups were compared with waitlist control, large effects on social anxiety disorder symptoms, medium effects on general distress, and even bigger effects with children and adolescents. We added that to this chapter, which I found interesting. Treatment as usual comparisons. CBT outperformed common factor groups on social anxiety disorder symptoms, but not general stress. And then equivalent improvement was found when group was compared to individual and medication. And there was one study looking at MBSR showing similar improvement between CBT and MBSR. Similar picture found with panic and obsessive compulsive disorders when group is compared to waitlist control, large effects. However, there were no differences when group was compared to treatment as usual, which mostly was individual medication and common factors comparisons. Now, there's another class of group, the way group is used that we introduced in the 2013 chapter. Group is often part of a treatment package. And this occurs when it's a trickier disorder. So group is one, and we call that group as adjunct. So for instance, when eating disorder patients are seen, they may be in a group, but they're also going to be seen by nutritionists, physicians. They receive individual therapy. So this meta-analysis came out of George Tosca's lab, and binge eating disorders was the most studied eating disorder, followed by bulimia. So those are the two conditions. When group was compared to weightless control, group patients were 6 times more likely to be abstinent than the weightless control at post-treatment. That was for binge eating disorder, and for bulimia it was 2.5 times. So quite effective, and that's a tricky population to work with. When group was compared with treatment as usual, the comparisons here were individual CBT, support groups, individual CBT plus IPT, basically common treatments. And there were no differences in abstinence rates or ED psychopathology. And these gains, if you will, so all were gaining, were maintained at both short and long-term follow-up. Another group as adjunct treatment that we looked at was PTSD. Number of PTSD studies, a mixture of combat and interpersonal trauma like rape and whatnot. 3 out of every 4 of those studies are tested a CBT protocol, and there was wide variability in structure, content, and length dose of these CBT studies. There were 5 studies that look at psychodynamic, IPT, resilience, and cognitive therapies. So that's the group of studies. And when these were compared to weightless control, large effects on primary and secondary symptoms, and higher remission rates. And then when active control was looked at, equivalent improvement on primary and secondary. And one of the interesting moderators in here, because of the between study differences, was gender. So women improved more than men, and the interpersonal and mixed trauma versus combat improved more, which we found interesting. Groups for substance use disorders are huge in the literature, and Lococo did a meta-analysis that included some of the most common treatments: CBT, behavioral treatments, mindfulness, DBT, integrative treatments, and so forth, across a wide variety of substances. So Gianluca looked at alcohol, cocaine, opioid, meth, and so forth. He left out tobacco. He found a small but significant improvement in abstinence when compared to weightless control. And in some studies, group outperformed individual, and others, there were equivalent results. So we probably need to think of that as a future area to explore. We had group in medical settings in our last chapter, and in the 2004 chapter, there were just a large number of breast cancer studies. And this is due to Spiegel's finding in the 80s that showed a survival advantage for breast cancer patients when they participated in a supportive expressive group. So, but when we got to that 2004 chapter, that was a huge number of studies exploring that. And basically the survival advantage was never really replicated. But the recent studies continue to keep going on breast cancer. They're testing CBT and stress management protocols for the most part. And there's improvement in emotional distress, fear, and resilience there. There's some third wave groups out there, improvement on quality of life with these groups. And the psychoeducational groups still are showing good strong improvement ratings in knowledge, treatment adherence, and quality of life. So that still is a solid area to make a difference with breast cancer patients. We added one this year, or this version, and it was pain. There was a meta-analysis that showed group outperformed individual with pain, and so we added that. CBT again dominates, but we have behavior therapy, ACT, mindfulness, and other models in this pain literature. And we grouped it by types of pain. So with fibromyalgia, group treatments outperform waitlist on pain, function, and distress. With chronic pain patients, we mostly have CBT and third wave groups there. They're showing improvement on pain reduction. And then with the specific pain, so these would be injuries, post-op and whatnot, the findings are mixed. And one of the suggestions there is that the protocols may need to be addressed a little bit more specific to the disorder they're trying to treat. Group continues to have a big impact, partly because of the chronicity with the seriously mentally ill. But, it's still flourishing. We had a meta-analysis on group treatment for schizophrenia. The 6 main treatments, they're producing a lot of studies, social skills, COG-REM, multifamily groups, psychoed groups, social skills groups, CBT groups, and metacognitive. This meta-analysis, because of the enormity of the literature, was reduced by looking at only studies that use the BPRS and the PANS to reduce heterogeneity due to outcome measures, and worked. This meta-analysis showed 3 treatments producing small effects, and the social skills, which has been around for a long time, UCLA SILS is one of the original programs, showing moderate effects. So the largest effects are with social skills. The meta-analysis also looked at treatment-specific outcomes. For instance, if you were doing a COG-REM group, a treatment-specific outcome might be executive functioning. With social skills, obviously, you'll be, social skills. The idea here was, if you get improvement in treatment-specific outcomes, is that related to the BPRS and the PANS improvement? And indeed, we found that 16% of schizophrenia improvement and 44% of general functioning improvement could be explained when you had improvement on target treatment-specific outcomes. So paying attention to those seemed to be important message out of that meta-analysis. And finally, a group has, with the seriously mentally ill, group has a long history with personality disorders. The borderline personality disorder literature has enough studies that we could do a meta-analysis on that. DPD is the most frequently studied, and there are large improvements. We looked at the other treatments, you can see them there, and there were no differences between DBT and the improvement seen in other disorders. However, there was a moderator. And as group size increased, patient improvement decreased. So keeping groups relatively small, which makes clinical sense, right? With that population. So, few conclusions, but just sort of a summary. We built this efficacy section on 10 disorder-specific group meta-analyses that use within-study contrast that rule out just a host of confounds. This really advances the literature because previous meta-analysis were using between-study contrast. So we used most exclusively within study contrast. 329 randomized clinical trials, 27,000 patients. This is one of the largest empirical summaries of the group literature, and you can see that the questions that patients may ask are addressed by this meta-analysis. Group outperforms waitlist. And the heterogeneity, for the most part, in effect sizes are absent, which means you can strongly hang on to that conclusion. 8 effect sizes showed significant improvement when group was added to treatment as usual. So don't change treatment as usual, add group, an evidence-based group. All effect size showed no reliable improvement, and group was contrasted with active treatments. Again, individual and medication are 2 of the most common. Group outperformed common factors in 2 of the 3 meta-analyses. Heterogeneity was higher in those active control comparisons, but there were 4 disorders that didn't have heterogeneity that you can take to the bank. And I want to transition with, don't forget, this is a call out to my buddy Mike, that manuals, techniques only support a small percentage of patient improvement. And you may be familiar with Mike's model. It's about 25 years old now. And he estimated, that about 15% of patient improvement is related to the model. He also estimated that common factors were twice that much, and that placebo is matching the technique. And of course, things out of our control are the majority. What our chapter really did was document the amount of improvement explained in recent meta-analyses. And we also added 3 meta-analyses on the therapeutic relationship. And the therapeutic relationship in group is a little trickier than an individual. You have member to member, member to leader, and member to group relationship. So last year, after we got the handbook chapter done, I applied Mike's model using the findings from our meta-analyses. And here's my application of Mike's model to group. I kept technique as the same, as 15%, but we know that 5 to 10% of patient improvement can be explained by therapist effects. So I threw that in. So it's not just the model, it's who the therapist is running the model, the group leader. Meta-analyses that we've published suggest that 23% of improvement can be explained by cohesion. Now, cohesion encompasses member to member and member to group relationship. And inside of those meta-analyses, moderator analysis, we know that 16% of improvement can be explained by leaders who are using group process interventions. They're using the group as a whole. And 13% of improvement is when can be explained when they're using and facilitating really member-to-member interactions. One of the meta-analysis was an alliance meta-analysis in group. And we found that 5% of improvement can be explained by the member-leader relationship. Now, this is primarily in non-CBT groups. So these meta-analyses really document specific cohesion and alliance measures that are reliable predictors of improvement, so a group leader could use them if they're interested in tracking and improving their group based on the therapeutic relationship their members are experiencing. It's hard to know. In fact, we published a study asking leaders to predict the therapeutic relationship of their members. Didn't happen until about session 8 or 9, which if you got a problem by then, the member is often gone. So I'm kind of a measure-informed, disciple. And I think it's particularly important to be that way in a group. So we added in this chapter a ROM piece, and I'm going to focus on the ROM and group. There were 4 routine outcome measure-informed studies that looked at groups. They had mixed results, but some of that might be due to the limited number of systems. There's only 3 out there that were used in these studies. One of the RCTs strongly supports change alerts, though. And there was that same study tested relationship feedback and found that relationship feedback can reverse relationship deterioration within 2 sessions. This is again, same leader, 2 groups, one group getting feedback, one group not getting feedback. And if they know there's a problem, they can address it successfully. So that leads to a promising development section. I'm only going to focus on one. We put in several. As Gerhard and I were finalizing our handbook chapter, we began a new project that incorporates much of the content of the handbook chapter. We work with the web developer of APA Division 12's research-supported website that's been out for probably a quarter of a century now. And we invited the senior authors of the meta-analyses I just reviewed to produce a disorder-specific version for a group of what Division 12 has been doing for quite a while. That website was just launched in Germany 3 months ago. This is a project funded by the American Psychological Association, the American Group Psychotherapy Association, and the German Health Ministry. And just to give you a feel, here's a few of the disorders. And each of those evidence-based treatments is a hot link. And if you click on that, you end up getting manuals, you end up patient workbooks, you end up getting links to training resources so that you can actually apply this to group treatment. Let me see if I can go. I can't go backwards. Oh, there we go. 2 other pieces. The therapeutic relationship as evidence-based treatment is a new phase for this evidence-based group treatment website that's now, so there's a tab there for it. What will appear there are the measures that I just mentioned that are linked to reliable improvement, alliance, and cohesion, and also alternatives to RCTs, which is basically wrong.
Gary?
I'm done.
Excellent.
So this is the where I want people to. We ended our 2014 chapter with this. We went to the group leader to have these 4 things, an evidence-based group leader to have these 4 things. Research-supported treatment and practice-based assessment is on that website. Practice guidelines are in the meta-analyses. And we think, well, there was an article we wrote called "The Future of Group Therapy is Bright." I hope what we've done is give you a little bit of a feel of why we think the group therapy literature is bright. And I'll stop there.
Yes, excellent. Many thanks, Gary, for this wonderful presentation and summary of the effectiveness of group treatments. Very, very impressive. Also the website and also the measurement-based care element. We are a little bit further along in time, and Gerhard already uploaded, but I think 1 or 2 questions. We can go a little bit longer today, given that we had also a little bit longer introduction today from me. Is there any urgent questions, or we move all questions to the end? Is there anybody? We discuss both presentations on increasing scale, because that's a major topic today. Is there anybody?
Perhaps 2 questions, but brief.
Yeah, John.
Is there any evidence that individual therapy is better than group therapy?
So the way to answer that,
Yes. Yeah.
so we had enough studies in that meta-analysis published in 2016 where we could look at a few disorders and look at a disorder level. In those instances, the outcomes were the same. So it'd be mood and anxiety disorders for the most part. But my sense is if as we gather more studies, there may be disorders that we can test to see if there is any evidence to support individual being better. I think that moderator that I showed you on the personality disorder suggests that a group needs to be small enough for the group leader to really manage some of the complexity of borderline personality disorder groups. So I'd say that in some ways the jury is out on a number of disorders. We simply don't have enough data.
So for the moment, the idea that as a broad statement that individual psychotherapy is the way to go is not supported as a broad statement of rather is to be treated as an ideological statement.
On an aggregate level, yes. On a disorder specific level, we need to be cautious.
Thank you.
So we had 40 some studies that would support the equivalence of outcomes when treatments were identical. When they are not identical, you see an advantage either for individual versus group, depending on allegiance.
Hey, excellent. So Gerhard, go ahead.
Okay, thank you for inviting me. We're a little bit late, but I tried to keep it short. So for the audience, so you don't need to stay too long. I wrote this chapter together with Thomas Berger, professor in Switzerland, and we're of course very honored to be able to get the opportunity to describe this fairly new format of delivering psychotherapy and psychological treatment. So I will run through the format because I assume not everyone knows this, and this is a huge field. For a time of just 25 years, it overruns. I would argue that the largest data we know about the effects of any psychotherapy is in this format. The largest efficacy effectiveness studies and everything, and it's a bit strange because we need to be a little bit cautious, so not replacing standard or group psychotherapy with this format. But just to say, I would like to give some background and some examples of new projects and studies, because I would like to say that this can actually be a way to innovate different forms of psychotherapies and indeed psychological treatments in general for the disorders and problems we haven't focused too much on previously. I was lucky to have two students knock on my door in 1998, having this idea that perhaps we could use the internet to treat headache. We ended up in GCCP on the first paper. I really thought they had a bad idea, but I said, well, let's go with it. So, and the rest is history. During that time, we had quite a lot of dropouts, but since it's a long time ago, we managed to handle that problem. This is a hugely heterogeneous field. When you hear online, digital, there are so many terms and loads of people delivering this treatment format as a leaflet, almost like a small app you can download, which is not the full psychological treatment, not the full psychotherapy. What I like to present is everything that you would get in a face-to-face or a group treatment, just presented in a different format. It's not a brief, preventive, it's a full therapy. Nowadays, we can use text films. Most of this is in the CBT format, but actually we've been testing psychodynamic internet treatments and interpersonal as well. So most, including actually online group therapy as well, a small few studies. In our approach as well, that Thomas and I describe in the chapter, we emphasize the role of a guiding therapist. And this has to do with things like alliance and knowing that there's someone there behind the screen who handles me. In the future, it might be an avatar or a artificial intelligence thing. But to date, the evidence that supports this treatment format is when a therapist is behind. And the support can be fairly easy. You don't perhaps need to be a trained psychotherapist, but you might need supervision from a trained psychotherapist to do it properly. And many things in trials can be handled much more effectively. I know when we tell people that we can run an RCT with 300 people in 2 months, they don't believe it's true, because it's never happened before. A controlled trial takes years. And I'm actually right now in the middle of a trial where we've recruited 240 people in 2 weeks, including structured interviews, psychiatric interviews before, just because of the distance, so you don't need to go to the clinic. There are so many reasons. And having said this as well, and that this might work, I'd like to convince you with that, it's not an either or. This in the future will be blended with other services, and I can go on forever about that, why there is something medieval with assuming that a client in a therapy will remember what you said in the therapy. Sorry, guys, they don't. So learning support. So we're trying to understand, why does this work as well as face-to-face therapy? Because it's obviously not the same. And one reason could be that you can return to what the therapist said in a text exchange in a different way than if you have to wait for 1 week to see your therapist again. Anyway, briefly, we use a platform that's extremely important. There's a lot of talks about apps and smartphone apps. The system both Thomas and I use, systems are responsive. It means that if you log in through your phone, it looks like an app. And if you use your computer, you don't need to think about it as well. Everything is very secure, and you can have chat sessions, you can have video sessions, etc., depending on what we're trying to achieve in the therapy. Just a few screenshots here. Not extremely posh. This is, well, technology makes a difference in the sense that it should not crash. People drop out from a treatment not because they didn't like the font, but because they tried to log in and failed twice. So technology is extremely important, but not what most people think when you talk about research. Oh, you have persuasive design, very good, nice pictures. Yeah, that's important, but it should be secure. And in terms of not failing, videos, broadband access nowadays, and interestingly, most of psychotherapy research been done on people who live in Boston, Oxford, you name it. Not so much in people living in Afghanistan or So this is a way to spread what we've learned, what we've gained from all these years of psychotherapy research, and test it, deliver it, adapt it to other cultural settings, So, and I will briefly just mention that. So this is our treatment platform here in Linköping, where these are the languages it's available in now. It's in 19 languages, and we're running studies in 15 countries, including places like Lithuania and places where there haven't been so much psychotherapy research ever, So it's important kind of proof of concept studies in that sense. We have had ethics approval of running world trials, but there's a lot of legal problems with treating. I know in the United States, it's even a crop between states in the US, but even within Europe, it's not that easy. So there are some legal issues with delivering treatment across the globe, and the concept of global mental health, it's a good idea, but it's easier than said than done, not from a technical point of view. Here's just a quick overview of what we've been doing, and I almost feel a bit ashamed that we've done so many studies and trials, but these are the conditions just in Sweden. And it's basically all conditions for which there is some kind of psychotherapy mostly CBT, but not only. But then on the list further down here, you will see some problems for which there's not so much evidence before, like adolescents with poor self-esteem. You could argue, do you really need to do an RCT on that? Well, perhaps instead of running yet another depression trial, you know. And there are some holes in the evidence tapestry, you know, over the years. Anyway, one obvious question, is this as effective as face-to-face? And these trials are difficult to run. You need to have people who are willing and able to do either group or internet-based or individual or internet-based. Our recent update in World Psychiatry here is now up to 30 plus studies, direct comparisons between internet-based guided treatment or face-to-face in the group or individual formats. And it appears to be as effective. Doesn't mean that it's everyone benefits from internet treatment, everyone benefits from individual treatment. No, but we don't know who it is. And I think, sorry to say, guys, when it comes to psychotherapy, there's no, we just cannot predict, you know. And there are so small. It's good with the alliance, right? But there's so much variance left. And I thank you, Gary, for reminding us of the unexplained variance we have in psychotherapy, which is huge, you know. But obviously, there are some common background factors, like being able to psychologically mind, being able to do homework, for instance. Not everyone can do that. I give you a quick example here of how this can be. Social anxiety disorder, I had the idea back in 2000 something early, when interviewing a patient for a panic trial, who ended up was not a panic person, was someone suffering from social anxiety. So I told my students, let's do social anxiety. I really didn't believe in it. I was skeptical because this would be like, not feeding the beast, but you know, if you have problems with meeting people, internet should not be the solution, I thought. But it seemed to work surprisingly well. And so we had this idea then comparing it against face-to-face. This was actually two different formats. There was Heimberg's group CBT versus our ICBT internet-based treatment. Non-inferiority seemed to work. We transported into Romania, and this guy, Bogdan here, he had this idea that internet treatment could perhaps work, but in Romania, the internet access by that time were around 25%. He didn't believe he would have any participants. When they opened up the study, I think they had to phone into our web guy on the Sunday, close the study. There are too many people reporting interest. So this is an example of a culturally adapted, translated, and a quicker way to disseminate across countries interventions, I believe. And here's to pay some credit to my co-author here, Thomas Berger. He's a really impressive guy, you know, because I had lots of friends here in Sweden when we started, and I got friends in Australia. He was sort of alone when he started in Switzerland. And this is one of the few, actually, internet-based treatment studies in French, because it was done in French. Yeah. A game changer in our world was when David Clark, the David Clark behind the panic circle and everything, who really didn't believe in this. I think he didn't believe in our studies and the findings until he replicated it himself with his own ICBT program. And it was now this is in increasing access to psychological therapy, IAPT. And so it appears to work. By the way, I need to mention there are so many things why I won't mention because we lack of time, but we have investigated side effects, negative effects, and been able to do that in patient level meta-analysis. Around 5% or something like that experience negative effects. It's been sadly non-reported in previous psychotherapy studies, but now we've done it, and there's always a risk, right? If you report that some people don't do well, they might even be worse. Our colleagues in pharma colleagues might say, yeah, you have side effects as well. So why choose psychotherapy? if you have side effects, but these are minor. One way to review the evidence, so we mentioned this in our chapter, is to do something called umbrella reviews. It's in the situation where you have new meta-analysis coming out almost on a weekly basis. It's a nightmare in this field because there are many trials being run, and then people across the world, actually quite a lot from China as well, now doing meta-analysis. So we need to keep track of the quality of those meta-analysis. And so it's a good thing with meta-analysis. I'm really a fan of them, but they are becoming so common now. So we need tools to evaluate the quality of the meta-analysis, and they exist. So this is one dating a few years back. We included 9 recent reviews because the old meta-analysis are not so interested if there are new ones 10 years later, and it was not possible for specific phobia and OCD, might be now, but still not. So this is quick and dirty summary of this. Panic disorder, in that one by Andersson and the guys, was just 12 trials, large effect size. This is between group effect sizes, usually against wait list or retention control or treatment as usual. In my country, Sweden, it's always treatment as usual because we have tax-funded healthcare. So no one is never without treatment, if they want to. But still, it's sort of waiting. And then we have social anxiety disorder, GAD, PTSD, and then major depression. And this is a smaller number of study because these guys focused on diagnosed major depression. And I'm a bit of a skeptic when it comes to psychiatric diagnosis because they are dimensional. So why exclude someone who almost has a major depression? In particular, an old person, by the way, they will say no to cardinal criteria and have a BDI score of 30. So won't get the diagnosis, but have the problems. And the same goes with adolescents in the other direction. They might not get the diagnosis in an interview, but they score extremely high on their scores, self-report scores. So age-adjusted self-report questionnaires is something we will need to consider. Okay, and then I mentioned the psychodynamic, because people were so surprised that we did this, we thought, and this allegiance, yeah, that's a problem. But in my allegiance is that I don't care what psychotherapy form it is, because it's an independent variable in our research. If I have too much vested interest, so and I used to tease my CBT colleagues, I'm a CBT therapist myself, by showing these results and then asking the people in the audience, guess the treatment. And they see their jaws drop when I said it's psychodynamic. But this is psychodynamically oriented, guided self-help. So it differs, it's clear psychodynamic constructs, and we will be well accepted by the psychodynamic community, by the way. So that's an interesting thing. We've done a few more of those on adolescent depression, for instance, recently. There's much less done on the more specific, like OCD and those disorders, where you might think perhaps that you need to adapt and change a little bit of the psychodynamic therapy, but who knows? Right. Now over, I'm speeding up here in the interest of time. Here are some topics, examples of topics where I think we can help the psychotherapy community by at least doing initial work that then needs to be replicated in face-to-face trials, and why not group trials, And loneliness is one example. We did a pilot RCT. We've done a larger RCT as well, and comparing against interpersonal psychotherapy online. And that was actually not as good as the CBT one. So this is one example on loneliness. Here's another example of learning by doing. After 500 adolescents cases have passed my ears, together with my former PhD student, we said, hey, there are too many of these girls saying that the real problem is poor self-esteem. Shouldn't we do a study on that, a program on that specific problem they report? It was the same group, anxiety and depression. Several of them had a diagnosis, but that was how they'd explain in their own words. And that's something we need to consider in the psychotherapy community. Are we using our clients' words of their problems? Or are we using our psychiatric manuals words, which sometimes, in particular in a cross-cultural context, can be really problematic, because some people don't want to identify with the concept of depression. Low mood, that might work, but not depression. Right, and then it's quickly, this is a pilot RCT, and it's a bit political in a sense, because we had some news about many young people and other people as well feeling really bad because of climate change. And then, and actually, I've seen several people say that if people feel bad because of the climate, they should not be treated. You know, they should feel bad. And my colleague said, well, actually, if they feel depressed and sad, shouldn't we try to help them so they can be more engaged climate activists? You know, and it's actually true that some of the people who sign up for this study, and it's a small pilot still, were activists, you know, and they felt almost a concept like climate depression, you know, suffering and this hopelessness, these dangerous feelings and emotions and thoughts that it's not worth it, you know. So we were able, oh, sorry for the busy slide, but anyway, we were able to have some initial findings. This is the only study in the world on people suffering from the climate. We did several studies during the pandemic as well, and we covered those. And we were encouraged to write a little bit about that in the chapter as well in the book, and we did. But now we all want to forget about these lost years, right? So I saved you from the slides on the panic of the COVID-19 studies. Anyway. Final remarks. What I appreciate with this format, I work as a psychotherapist myself, face-to-face. So what I appreciate with it is that it makes it quicker to test new ideas. Like right now, I'm hoping to get some funding to help people who have financial problems. If you check the correlations between financial worries and psychopathology, these are quite large. They beat the lions. Very, very strong. And now we're moving into a more people even in my country now have financial problems. So that's something we would like to work a little bit more with as well. And then the tailoring aspect. And I didn't show you this, but I can mention we have now a format of treatment where people can themselves choose what they would like to work with. So even if you're a depressed person, you might prefer to work with stress, because that's a problem you have as well, because comorbidity is the rule rather than the exception. And some of our clients, this is not the first time they see a psychotherapist. It might be the third time. And hearing this CBT therapist tell you the same story the third time is quite boring. So preference, it's actually been found to work just as well as if we tailor the intervention based on their preference. So that's something to consider as well. It's totally new. We're the only ones doing it, but perhaps it's what clinicians always done. They check, what are your problems? What would you like to have help with? And they respect their clients' preferences when working. But in the manualized treatments, it's been hard to squeeze in preferences, because week 5, you should do this. In group treatments, that's the difference, because then you need to have everyone on board. You know, that's obviously you cannot be all over the place, but it's an exciting new development. So by that, and the implementation thing is quite obvious. Strongly like to stress, I don't see this as a replacement. I see it as a complement, as a research tool, and we will need some time to get used to modern information technology. You know, some young and old people are too much connected, hooked with their smartphone, and too much time on screen. What I presented is not screen-based treatment. It's go out, getting instructions, advice, go out in real life. That's very important to stress that. Okay. By that, I would like to end and thank you for your attention.
Excellent, Gerhard. Thank you very much for this great presentation. Another way to increase scale and to disseminate. And I think it's also nice that you made that point. It will not replace individual therapy. But that leads me already almost naturally to this first question I have, and then we open it, of course, which really I asked this myself already when Gary started, and it's a question to you both. Do you have any differential knowledge in terms of individual therapy versus group versus internet therapy? Do you have any from, the literature you have scanned through, this huge amount of work you have time you have spent into this, into the chapter and in your research over so many years? So is there anything you would say pops out, would help us to make some differential response models? What works best for whom, in a way?
Before Gary, I squeeze in.
Yeah.
Preferences is one thing. I know that there are people with social anxiety who would not have been helped by a therapist, but are helped by when it's a self-help treatment from a distance. And there are vice versa. Some people are not helped. So it's an equal sum. We just need to know what are these moderators, And another thing in psychotherapy research, we get rid of the moderators because we have inclusion and exclusion criteria. So we drop all the ones, and then we're surprised that we don't find any strong predictors. Obviously, so that needs to be tested in real life settings.
Yes. That's the big point of measurement-based care and large data set options and possibilities, for example, with IAPT samples. Yeah. Gary, what do you think?
Yeah, I want to echo Gerhard's point on preference, because a part of what you got to do, people prefer individual. There have been a few randomized clinical trials where they measure preference and then randomly assign people to group or individual treatment. And the outcomes are the same. But in real practice, if you're not addressing preference, you're going to have attrition, and attrition will kill a group. And then there's something we added to this handbook chapter, Wolfgang. It's a burgeoning literature. I don't know if we know enough yet, but attachment style. There's some interesting interactions coming out of the attachment literature that I think we offered some preliminary observations, but I think that as that literature grows, that may help us as well. And I'm guessing probably there's a relationship between attachment and preference. So those are the two pieces I'd add.
Interesting. Yeah.
I can add to Gary's interesting anecdote. We actually all compared group treatment versus internet treatment and asked for preferences. But then we asked about preferences after the treatment, and they've changed their preferences. So the ones who've been randomly assigned to group preferred group now. So obviously you cannot have any preferences for anything you don't know. That's actually a problem, decision making. And I would like to add that we in psychotherapy should perhaps talk more with our colleagues in other branches of psychology, like cognitive psychologists and etc. That's something we don't know anything about decision making in therapy. For instance, that's extremely important to decide when to go to a therapist. Yeah,
excellent. Yeah, Louis, you have a question.
Yeah, I think related to that, what you just presented, Gerhard, as the result doesn't surprise me too much, but if I'm right, I think in very early, perhaps in the 70s, if Alan was here, he could help us. I think that the humanistic therapist did create some kind of expectations manual or kind of way. This is what you should be expecting from a Rogerian perspective. And I'm just wondering if, you know, one of the issues, Gary, you mentioned with regard to private practice, if one of the role of evidence-based researchers and clinicians is to actually have a descriptions for the clients to be aware, this is what, you know, these are the frequent apprehensions that people have about group therapy or internet, and this is what you should be expect to have, and that from a clinical perspective, we actually may give a more fair chance to non-individual therapy.
Yeah, so most of the group research happens in institutional settings, clinics, hospitals, counseling centers. So it's tricky to know when you move over into private practice, because that you just don't have much research on groups in private practice going on. But most of those settings, Louis, have a pre-group preparation approach, which helps clients hit the ground running. And about 20 years ago, maybe 25, we developed a little, we originally called it a group selection questionnaire. We changed it to the group readiness questionnaire, because it was, you know, how much is a patient not wanting to go into group, and that then would give you a gauge of how much prep you had to do to set expectations, right? But it's tricky.
I mean, in our clinic, we have in the waiting list when we offer internet treatments, there you have some people who really love that and start right away, with others say, when I'm successful, will I see even a therapist afterwards too? So they are concerned that they will not have a real treatment afterwards. So it's a good point in terms of the interest. Yeah, Gerhard.
I have another thing, very interesting thing. CBT and most psychotherapy includes getting good relationship, advising clients, and learning, presenting some new ideas. But we never measure, do they really get it? Do they learn? So we actually done that in numerous trials now. We have strong effects of learning and how certain you're about the knowledge, but it's not so correlated with outcome. And I'm glad for that, because there's so much redundancy and, you know, attached. If I'm not so happy if I have a construct that strongly correlates, because we're probably measuring something, same thing with self-report questionnaires. So we need to look at other places and see, and this is one thing that's almost no one's checked, you know, more of the educational sides. I know Alison Harvey in the US been just having 45-50-minute sessions. Might not be a good idea from an attention point of view. These small basic things on how therapy is done could perhaps be a way to improve or at least learn what do people remember. There's almost no research if what you remember 4 years after therapy. Is it good to remember? It's good to forget. Well, when it comes to relapsing depression, it's pretty good to know what to do if you're in a new episode after 4 years. You know, it's pretty good to know, but we don't know. We haven't checked so well. Yeah.
Denise? We don't hear you. Yeah.
No. Hello. Well, thank you very much. Wonderful presentations. I was thinking of future developments or perhaps further, which are not included in this presentation, but I think should be taken into account. One is internet interventions with children. The pandemic gave us an extraordinary opportunity, and I think that qualitative research needs to be done. I do not work with children, but I was very surprised, for example, that therapists told that when a child did not like the therapist's words, he would mute the therapist, which I found lovely. An internet shape for resistance, with it, fantastic. And at the same time, it gave them the chance to see the real world of the child, the real attitudes of parents, his room, his pets, his brothers and sisters. So that's, I think, we should also try to find or develop qualitative research. And the other thing that I think, at least I'm not an expert in internet interventions or research, but I have not found, or perhaps it needs to be done, assessments and research on hybrid interventions. Because I remember a very, very wise therapist when this started, before the pandemic. He said, okay, if you have to do internet treatment because the person lives very far or whatever, but the first interview should be in person. Because third, I mean, in 3 dimensions, I want to see how he smells, how he looks, what it makes me feel, how tall he is, how fat he is. So that's, I think, interesting. And not only in this sense of a diagnostic stance, but very recently I had a friend who died from cancer, and he lived in distant places. So many of the consultations were through internet. But the key consultation in which he was told that, yes, he had cancer was done on the phone. And I found that immoral.
Yeah.
Immoral.
Strongly
Absolutely
agree.
immoral.
Yeah.
It's different when you have a follow-up, but that which will go change, you're telling the other one, and there is no cure. On the phone, no, thank you. Okay, thank you.
I quickly ask, every RCT nowadays is complemented with a qualitative study. So and so like adolescents with poor self-esteem, there is a qualitative study published on that as well. Their experiences. Sometimes they're viewed with suspicion because they're so happy. So we deliberately try to find some of the participants who are not so happy to get their voices as well. And in real life, when it's implemented, in many places you start with the face-to-face meeting, but there's a thing called telephone. Heard of it? Yeah. And telephone psychotherapy been practiced so many years all across the world, and during the pandemic we had to resort to that. So it actually works, but in clinical practice, very often first the meeting, and then we can have the rest of the meetings through. So you're onto something here, and we call it blended treatments, where you blend. Why stick with one format? Test what works, and for the individual clients. A bit good advice. Yeah.
Gary?
I was thinking of pandemic trauma when you were describing hybrid groups, because our clinical setting had to go to internet-based treatment, and this is a qualitative answer. We don't have any research on it, but the groups that were going and then moved to an internet-based approach seem to do much better, less attrition than when we were trying to start a group from the internet. So I think there's, at least in group, there's something about being in the room and getting a feel of the folks, and then you move to internet. Now, this is a natural experiment, and I raise it more in a qualitative way rather than with any confidence.
Was that internet or video-based treatment then?
We went to Zoom.
Zoom, yeah. Yeah.
And we also, I mean, we were wheeling and dealing. So some of our patients, we ended up keeping some of the group physically there with an owl. If you know what an owl is, it's broadcasting at least the people sitting in the room. The patients, if they were going to move to internet, and maybe Gerhard, you know this from your research, it seemed like they wanted everybody on internet, like in a Zoom situation, then split between in person and Zoom. Now, again, this is just, running 25, 30 groups a week and trying to go through the pandemic. Any comment, Gerhard, on that?
Well, you know, don't we all like to forget that terrible time when we, yeah, but there might be some good in it, you know, particularly people who live from a distance, you know, and yeah, but we need to consider the ones who won't come to us because, you know, the expectation, you know, once they're there, it's fairly easy to have them. You can do this, you can do that, you know, but the ones who don't come, you know, that's what I think about, you know. So yeah, we didn't do so. There's not so much research on video therapy.
Okay.
There's so much research on guided self-help with programs and chatting a bit, you know, but the real-time video therapy, no, not so much done, you know. And I'm not so convinced that there's something awkward, strange with, you know, all in the face, you know. So I'm not. There are many people who don't like it. That's the point.
We had to do this too during Corona. We just switched between face-to-face to internet, and then since we track progress all the time and the alliance, and it didn't make a difference, but it was people who had already started treatment. But it makes a difference if you don't have the first session face-to-face in terms of the how well they participate at the beginning. But it didn't make a difference when they started and switched to video treatment during Corona in terms of the symptom change session by session, as well as on alliance. I think there is one commentary. I thank you all for being around so long, because we really did go some overtime today, but we started earlier. So there's also one commentary by John from a public health perspective. I would expect groups and net-based interventions to be more cost-effective investments, expense per person or per remission. What might be the research base for that? Maybe this is then the last question, and then we stop.
Quickly, Gary might agree. You know, the real from a societal perspective, therapy pays off. You know, if people just go to work 2 more days, then they, you know, and sometimes much health economy research, sorry if I step on anyone's toes now, is more from the provider's perspective. Of course, you know, and but we really need to be more brave here. There are some reviews of cost effectiveness of this internet-based, you know, they're cost effective, that's true, but we also need to consider quality of life and actually people work capacity and things like that, and quality of family life. So there's more to do here now. I think we're not selling our stuff well enough when it comes from a public health perspective. Yeah, we're better than we much better than we dare to say. Yeah.
John, there's an article in the American Psychologist that came out earlier this year. Senior author was Martin Whittingham, that addresses the question that you're talking about. It's really he joined with a medical economist. It's a fascinating article on the cost effectiveness of group treatment. So I'd point you to that.
Thank you very much, Gary. Thank you very much, Gerhard, for this wonderful presentations, and thank you all for the great discussion. And see you all on the 14th of March for our next webinar.
Thank you,
Bye-bye.
guys. Thank you, everyone. Thank you.